Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Welcome to Melanoma Matters. I'm James Larkin.
I'm Sapna Patel.
So today we're going to be talking a little bit about loco-regional treatment from metastatic uveal melanoma to the liver, heptazo. But before we do that, icebreaker warm-up question. What was the last thing you cooked? And maybe if it's a boring answer, just think, a bit further back of something interesting.
It's not boring. Actually, I watched cooking shows all weekend. I actually made a gazpacho last week because it's so hot and I had tomatoes and some bell peppers. So it's great. I actually drove it to Aspen and then because you eat at room temperature or cold, I made fresh gazpacho, blended it all, and then made fresh croutons as well, which was great. And so these garlic croutons, I took them anyway. Yeah, it was really good. I made homemade Caesar salad dressing, which is basically I don't like it so thick, so I use more milk and mayonnaise. And then it's anchovy paste, Parmesan cheese, lemon, vinegar, Worcestershire sauce. And so I've made that. So last week I had lunch at the hospital with my practice manager, and I actually brought my own dressing from home because it's really good. And it only has a shelf life of 7 days. So that's what recently it was gazpacho, croutons, and homemade Caesar dressing.
That's not a bad answer at all. And the whole Aspen thing, that was like, you didn't trust the food there. You felt you needed to take your own food with you, or what?
It was because I was leaving at this odd time, and I knew I would get there and be hungry, and it wouldn't yet be time for anything. So I had this great soup. That's good.
Yeah. Okay. Very good. Right, so let's talk about this paper, Annals of Surgical Oncology. Jonathan S. Sager is the first author. Just come out recently, I think.
Yeah. So this was the phase 3 focus trial, as what it was called. By the way, I thought it was called Hepzato, but you said Heptazo, so we might have to fact check that. I thought the approval was Hepzato. Anyway,
I'm sure you're right and I'm wrong, but yeah, let's check.
No, I could have easily transcribed some letters there, and I don't think it's in the paper because this is generic. So this was the focus trial, randomized phase 3 trial for metastatic uveal melanoma patients, where they were randomized to receive this percutaneous hepatic perfusion Melphalan, which is a catheter and a drug. So that's really what this approval is. So Melphalan hepatic delivery system versus investigator's choice. And I'll just briefly say the short answer is that the investigator's choice was either transarterial chemoembolization, TACE, pembrolizumab, ipilimumab, or dacarbazine. But actually what was happening, and this was a fear during the tebentafusp studies, it's a fear in this disease because there is no gold standard. There was no. Now we can argue we have some gold standards comparisons, but the investigator's choice arm historically was pretty unappealing to these patients. Pembrolizumab, ipilimumab, single-digit objective response rate, dacarbazine 0% objective response rate. There was TACE here, so another liver-directed therapy. Arguably, that was reasonable, But what happens is when patients get randomized to that investigator's choice, they're uninterested and they'll drop out. And even the best counseling to patients, we really, want you to stay on study. Let's give it a chance. And even the best counseling didn't prevent the high dropout rate. And, with that high dropout, you would never be able to analyze a study for overall survival because you have to have events. Basically, otherwise, all your events are on your investigational arm. And anyway, it's just bad, study conduct when that happens. So there was a real fear that the study would actually never finish, right? Because if you have to randomize...
Yeah.
Go ahead.
No. So this is a massively important point. It'd be good to talk about this, actually. So I mean, how do you mitigate this dropout risk with unappealing control arms. I mean, there's things you can do, right? You could blind, but sometimes that's not feasible. You obviously ask people to go into studies with good faith. I mean, and that's what I say for this type of situation. But at the end of the day, if someone decides they want to drop out, the rules say they're allowed to drop out. So, what I mean, the study, I don't know if we talked about it before, I was thinking a bit about, there's lots of examples where it's been an issue, but Checkmate 37, which was Nivo versus chemo in the refractory setting years ago now, probably 10 years ago now. The publication for OS was in JCO, I can't remember when, maybe 5 years ago, something like that, but I can't remember how much dropout there was, but quite a lot, maybe 10% in the control arm. And exactly to your point, it then becomes difficult. I mean, could you mandate overall survival follow-up from registry records without consent, et cetera, et cetera? I don't know. What do you think?
Yeah, I mean, synthetic control arms like that from registries, I don't know if the regulatory agencies are ready to approve that as their control. You could randomize 2-to-1, and that then you tell the patient there's more likely a chance you get the interesting, or the investigational arm. I also think it's making sure that that control arm has what they would get would they not enroll on the study. So the issue, I think the biggest issue is at the time of this study, what would people get if they weren't eligible for this trial or have access to the trial? Maybe they were getting Ipi-Nivo. And the problem was none of the investigator choice options were that combination. And so people were dropping out saying, well, I want to take this combination. It wasn't one of the choices. I think if there had been that choice in there, you would have had a little bit better retention, because you would say to the patient, this is what I'm going to give you anyway if you don't get on the study. But when you have a control arm that doesn't include what a patient might get anyway or in the real world, I think that's where you start to see this kind of high rate of dropout. Yeah. So interestingly, the company, basically scheduled a conversation with the FDA, with the US regulatory agency, to say, what should we do? You've asked us to do OS. You've asked us to do it controlled like this, and we're having trouble. And the regulatory body agreed. They saw the rate of dropout. They saw the slow accrual due to this, and they agreed that it was reasonable to drop the investigator's choice and just turn it into a single arm trial. Now, I don't know the details well enough to know if there's going to have to be a confirmatory study, because historically, when the FDA approves things based on a single arm, we think of those as a phase 2, not a phase 3, but here it's called a phase 3, a single arm phase 3, which is interesting. But when the FDA approves things on either accelerated or on a basis of a phase 1 or phase 2, they usually need a confirmatory phase 3. I don't know if that's the case with this. We can try to look it up and see. But ultimately, the study ended up enrolling 102 patients with metastatic uveal melanoma. And then what happens is you get this Melphalan liver delivery system for a maximum of 6 cycles, and you space them 6 to 8 weeks apart. So there's a pretty long treatment-free period between each of these perfusions. And actually, there's a Swedish surgeon, Roger Olofsson Bagge, who was recently in Stockholm, and he was so lovely and took me around to the old town and showed me things. And he has a really nice explanation of the difference between infusion and the difference between perfusion, which I think had been a little bit lost on me. And I can't recall it. So maybe we can reach out to him so he can clarify and we can put it in the fact check. But this is a perfusion, although he might argue that this is more of an infusion and not a perfusion. So stay tuned on that. So this treatment in the liver, requires an entire specialty care team. It requires somebody to place these catheters. You're essentially putting the liver on a bypass circuit. So you're blocking inflow and outflow of the blood. You essentially are placing the catheters in such a way that you get all the blood out of the liver, and then you saturate it with Melphalan. You saturate the liver, you put Melphalan directly into this closed system of the liver. You saturate it for a short period of time, and then you, through the catheter system, take the Melphalan out and put filter it, through a filter, put blood back into the liver, undo the catheters, and so forth. So very little Melphalan should be getting systemic. That's number one. And number two, this should really be cytotoxic to a point of like not losing your hepatocytes, but losing the tumors in the liver. You might remember some 13, 14 years ago, there was essentially the same study was done. And the issue there was the company didn't manufacture the filter that went through this catheter. And so there was quite a bit of Melphalan that was getting systemically so it was passing through the filter, getting back into the systemic blood. And when they released the catheters, was getting into the body. So they had a pretty high rate of cytopenias in a population. We should remember that the average age for uveal melanoma is 6th and 7th decade of life. So that's 50s and 60s. And when you put Melphalan into that patient population, you could actually have real cytopenias. And then they had some deaths from it that the FDA deemed was too high. They had a crossover design. So the best alternative care arm could get Melphalan hepatic delivery at progression. And then that muddied an overall survival endpoint. And then they used an endpoint called hepatic progression-free survival, which was just about progression in the liver. Highly relevant for this disease, but the FDA essentially said, don't ever use that term with us again. Don't ever bring us a hepatic progression-free survival study again. So that's why you don't see that as an endpoint for uveal melanoma studies, though realistically, that's the endpoint, we look at as progression in the liver versus not. So I think
so Sapna, I've got loads of questions already. I think Roger works in Gothenburg though. Or maybe you just met him in Stockholm, right?
He's such a lovely guy. He came to Sweden Stockholm by train that morning, and then delayed his return because he realized, I had nothing to do that afternoon, and so took me around that afternoon, and then went back to Gothenburg. You're right.
And I think he does ILPs as well, from what I can understand. So that leads to my question, really, which is how analogous is this to an ILP? Because it sort of sounds like it is, at first glance, I suppose. And then the question in my mind is the extent to which the Melphalan sort of exposure tissue penetration, if you want to call it that, is similar or not. And we can maybe fact check that afterwards if you don't know off the top of your head.
The Melphalan is similar to
if you use Melphalan for an ILP.
I got you. So I think for us medical oncologists to conceptualize these, they're similar. It's basically putting a limb or an organ on a closed, unit, closed circulation, and then infusing or perfusing through there and then releasing. I'm certain the technical aspect of it to a surgeon or a proceduralist is quite different. But I think conceptually for us, that's the same. And, we have stopped really doing limb perfusions mainly because of the effectiveness of systemic therapy. Here's hoping we get that way with the liver. Now, the liver is just a unique immune environment. So despite really good systemic therapies in even cutaneous melanoma, the presence of liver metastasis does portend a different outcome than if you had it just limb soft tissue disease only. So there may be a little bit more to it, than just effective systemic therapy when you have an organ like the liver. And then as far as tissue penetration, I don't know the answer. That's a good point. Melphalan for a soft tissue versus Melphalan for hepatocytes and then tumor in the liver. That's a good question. Yeah. I mean, the obvious criticism is, why are we using such a pitiful drug? Why is Melphalan our drug of choice for this, rather than something like a checkpoint inhibitor or something like a TEBI, something with some modicum of efficacy? And the really kind of bad answer is, well, this is what we always used in these types of procedures. In a limb perfusion and a liver perfusion, we basically used chemotherapeutic agents, even though we have study after study showing they're minimally effective in this disease.
Yeah, I mean, there's some other interesting stuff as well. I mean, this whole dose response for cytotoxic chemotherapy, maybe not even just for melanoma, maybe for solid tumors. So, we're limited, obviously, by the systemic toxicity. But then, I mean, I was just thinking about ADCs, actually, if you see what I mean. That would be another way of delivering potentially higher doses of cytotoxic drugs. Maybe it doesn't even matter what much what the drug is, to the point about Melphalan, and actually maybe at the top end of this dose response curve, if you see what I mean, we might see some stuff that we haven't been able to see before. So, I mean, I think that's quite cool and interesting. And then the other thing was about body part specific PFS. So well, no, I was thinking about our favorite organ though, if you see what I mean, which is the brain.
Your second favorite.
So, but the question's going to be about all the brain met studies, isn't it? Because people do talk quite a lot about intracranial disease control, and we know it's not easy to measure. So I'm just wondering if there's any hierarchy of body parts when it comes to surrogate endpoints or not. I mean, you don't have to answer that, obviously.
Yeah, I don't have an answer for it. I mean, I know when I take care of these patients that what's happening in the liver drives my thinking. They could have lung metastasis. They could have lymph node metastasis. I could even change as I said to you, the hospitality of the liver with over and over using liver-directed therapy, and then it pushes the tumors out to subcutaneous tissue or lymph nodes or lungs, and I'm less concerned because I know now their survival is prolonged because we've controlled it in the liver. So what happens in the liver for uveal melanoma definitely drives outcomes, not unlike what happens in the brain for cutaneous melanoma. If you control it in the brain, then you will have a better survival than if you don't. That's really kind of science of the obvious. In our area. The other thing about this Melphalan hepatic delivery is just, I didn't really go into it, but my understanding is that you have to have proceduralists to put the catheters in, an anesthetist, so a type of limb anesthetist or cardiac anesthetist, essentially. These patients go hypotensive, so you need an ITU or medical ICU bed. You need blood transfusion. They will typically spend not just a 24-hour period in the hospital, but longer than that. And then you're watching, cardiovascular recovery as a whole, let alone, just things like coagulation, infection, cytopenias, things like that. Having said that, you get these nice treatment-free intervals. After you take one of these treatments, then you can go, and they've done, I think it might have been Ellen Kaptein's site that did a nice quality of life survey that showed your quality of life actually doesn't drop that much after getting this treatment. So that tells you that these patients are really, able to recover to a nice baseline, which was a concern with the previous version of this treatment 13, 14 years ago. So when the study was changed to a single arm study, they changed their primary endpoint from overall survival to objective response rate. The FDA agreed to this. And then they used this, 100 or so patients. Let me just briefly tell you here. So their objective response rate, now this will be global, but recognize that most of these responses are in the liver, was 36.3%. That's very, meaningful in this disease. We don't have any therapy that offers you that high an objective response rate. And then the follow-up question to that is, well, is it long-lasting or does it translate into an overall survival benefit? They did have some complete and obviously mostly partial responses here, but they did have some complete responses, which is important. And the responders had a duration of response for 14 months. So that's nice to see. Median PFS 9 months. Median PFS in this disease has always hovered around 3 months, which is the first time you really stage these patients. And it's even 3 months for the, landmark TEBI trial, because TEBI really has an uncoupling, low response rate, not necessarily a PFS change from historical studies, but it has this overall survival benefit. So that's the real question, is something like this treatment with a higher objective response rate, a PFS that's tripled from historical of 3 months, is it going to translate into an OS? And at the time of data cutoff, they didn't have an OS, I believe, for this study. Let's see, hang on. Yeah, they might have had an OS between patients. Yeah, we can fact check it, but I think the last time I saw this data, they didn't have an OS yet for a median for this study population. So that's, interesting. And then it comes to side effects, of course. And think the bottom line is this is a treatment that does have all the technical aspects that I described, and as a result has some real side effects. Let me get to the side effect table here. So you do want to usually be proctored at your site before you onboard this, meaning you want to have somebody like Dr. Zager or, the guy from Southampton who'd done so many of these, come watch one or two at your site just to make sure you've got all the things in place. Maybe not unsurprisingly, it's cytopenias that is the major complication here, thrombocytopenia and anemia. So thrombocytopenia grade 3-4, 54.7%. So grade 3-4 thrombocytopenia. So you do have to watch that, and likely in this patient population with catheters that were placed into the arterial system, you definitely want to watch for bleeding complications. Anemia in a third of patients, grade 3-4, leukopenia, neutropenia, another third with those. And then, it is a liver-directed treatment, so we always see a fluctuation of liver enzymes, both their hepatocellular enzymes and your cholestatic enzymes, but those should be transient. They're quite low numbers here for grade 3-4. There's some troponin stuff, hypotensive stuff as well. Febrile neutropenia, obviously, you would want to watch for because of the intervention of this therapy. But, again, it's no small thing to watch for, but these are manageable side effects once you see them, and apparently not impacting a patient's quality of life, which I think is good to hear.
So, that's really interesting. Any sense of if you could predict in any way, especially the cytopenias? So, I mean, we've been doing ILPs for a long time. So our patients have ILPs even now. We've talked about before with effective systemic treatments, and so I get a sense from talking to the surgeons that if they're worried about some of the technical aspects of the procedure, it's all about systemic leakage basically in terms of risk of side effects outside the limb I'm talking about now. But is there anything analogous, do you think, here in terms of how well the procedure went, quote unquote, in terms of risk of side effects, or is it's sort of completely unpredictable? Question one. And then question two, while I'm speaking, is about the baseline characteristics and how they look in terms of the patients in the clinic and what you're thinking about use of this treatment, I guess.
Yeah, I don't know the answer to your first question about how to predict the risk of these cytopenias mainly. In full disclosure, I didn't run this trial, so I only know it from a distance, not from actual experience. Certainly, I had patients go for this treatment, and so I could review their charts, but I don't really know that I have enough experience to say what's the prediction. I could read a little bit more about it. Maybe there is something that could tell you who could have these side effects. I think the difficulty becomes when this is a therapy that's approved, and these side effects hopefully are recoverable. Even if you could predict that somebody's going to get it, do you offer this treatment or not? Probably you still are obligated to offer it. The second question about how do you maybe pick the characteristics of the patient. So I think one of the things for uveal melanoma that we're not consistently doing, but that I think is very helpful, is to step back and say, first of all, how many tumors do we have in the liver? And, our radiologists are so busy, but when they use terms like numerous or too many to count, that's very subject to their own opinion, right? How many is too many for you to count versus for me to count? Some radiologists might say after 10, it's too many, after 20, and what does numerous even mean? So those numbers are not helpful. A cancer patient and their oncologist need a much more quantifiable number, not down to the exact, but a range. There are approximately a dozen tumors. There are between 10 and 20 tumors. There are between 20 and 50 tumors. There are 3 tumors, So we need some sort of quantification of the number of tumors, the size of the largest tumor, and then an estimation of how much of the liver is involved. And that last part, we're not really seeing in radiology reports. We talk about it in uveal melanoma specific tumor boards or case conferences. We'll talk about percentage liver involvement. That's the key aspect here. We think uveal melanoma patients will start to be on a sort of fulminant trajectory when they hit certainly 75% liver involvement. But when they hit 50%, 50, 60%, you'll start to see these liver enzymes change and maybe not actually normalize. So you'll start to see your ALT, AST, your bilirubin start moving, maybe not, fulminantly until it gets more liver involvement, but that's where it tips and you can start to see it. And I equate it to sort of bubble wrap, right? Your hepatocytes are the bubbles of bubble wrap. Once more than half of them have popped, they don't regenerate. I mean, liver can regenerate, but not in the course of this disease, not in the timeline that you have. So these bubbles have all popped. They've leaked all their AST, ALT. The spots in between the bubble wrap are like your bile ducts, so bilirubin and things like that. But when those start leaking, you'll see that when about half of these bubbles are popped, and then you don't have as much reserve. So, and the popping is involvement with tumor, in my analogy. So I lost my train of thought of where I was going with all of that. Oh, other than to say liver involvement. So when
I was going to ask you a question about that, because this is really interesting. I know we're on 25 minutes already, but what about AI here? Because that sounds like it's absolutely crying out for AI on MR livers. So that's one question. And then the other one is about liver enzymes in the normal range. So I've heard a lot about this outside the cancer context of whether, let's say, an ALT in the upper half of the normal range means something or not. Are you aware of any data here or not?
I've not heard that. I've heard it with respect to thyroid, that your TSH can be in the normal range, but if you're riding on the top end of that TSH, they'd rather start you on treatment even in the face of a normal free T4. I've not really heard this about ALT, AST though.
Yeah, Peter Attia is obsessed by it. Like, he says the normal range isn't even a normal range, and he's talking about kind of metabolic health, right? So the question stands. I've never thought about looking myself, but it's kind of an interesting question, especially if we don't really have any good tools.
Yeah, we could go back and look in, because a lot of these patients are coming into this trial with normal ALT, AST. We could break that down into the normal, with the difficulty being that the normal from institution to institution varies. So then a normal top third might also, it'll catch a different group of patients maybe. But it's important to know here that 80%, 79.1% of the patients on this study had less than 25% liver involvement. So we would consider that to be pretty low burden, although they were of the M1A, M1B size. And we've talked about this on a previous podcast, the difference between M1A and M1B in uveal melanoma. So only 38.5% had less than 3 centimeters. More than half the patients had 3 to 8 centimeters worth of tumor. So they had a decent amount of tumor, but a low amount of their entire liver consumed by it. So most likely these are patients with bigger, sizable tumors, but few in number, rather than that miliary pattern of small tumors, although they must have had some of those. The bottom line is this is, you got to look at that scan from almost the coronal view, if you will, and just get a sense how much of that liver is involved. I'm not sure cross-sectional gives us, looking at kind of human anatomy, the same view. So look at that coronal slice front to back and just get an estimation. Do I have a third, 2/3, or more than 2/3 of the liver involved? Or if you can get it as fine as by quarter, look at it like that. And just know that, like, the less liver involvement you have, the better you're going to do therapy for therapy. And that's what they had in this trial, mostly less than 25% involvement. Again, there's probably some continuous cutoff there we could look and see. But ultimately, on the basis of this 100-patient phase 3, the FDA did approve this. What do you know about approval in Europe and the UK or Australia?
Nothing is the short answer to that question, so we'd need to fact check that. And the other question is, what's in the public domain and what isn't, and then all of these, questions about acceptability of quote unquote non-randomized data, etc., etc. So it could end up being quite a long answer, I suppose. But so who's the right patient for this strategy in the clinic? Because it's available, and I'm assuming it's reimbursed, so you can use it if you'd like to.
Yeah, it's reimbursed. It's not really operational at a lot of centers in the US. And so it's for a patient who's willing to travel to one of those centers. Right now, Jonathan Zager practices at Moffitt in Tampa. I didn't mean to presume that he's not going to be practicing there. I just meant to say in this moment, it's at Tampa at Moffitt Cancer Center where Jonathan Zager is. It's also in Tennessee at a site there. It's at Thomas Jefferson in Philadelphia. I think there are some West Coast places that are onboarding this, but because of just you need that technical team, the anesthetist, the limb anesthetist, cardiac anesthetist, et cetera, the surgeon or the interventional radiologist, who's really the key player here, as well as intensive care support. It's not easy to onboard for this rare cancer. It's not easy for every hospital to turn on. So a patient who's willing to travel to one of those centers every 6 to 8 weeks, maximum 6 times. A patient with otherwise good cardiac fitness, because this does take a whopping toll on your cardiovascular stability for the period of time that you're under the procedure, and then recovering with all those cytopenias. And then truly, the question is, does this have to be an untreated population, or can they have seen previous treatment? I think there's a bit of caveat here. There had been some early studies, and there were only case reports in the liver of people who had taken this Melphalan and then progressed and then gone quickly onto Ipi-Nivo and then had sort of colossal, fulminant liver events. We don't know if sequencing the other way is an option. We really don't know how to sequence Tebi and this treatment. Does one come first? This treatment's not HLA restricted, so it's really for anybody. But I would key into that point that, less than 25% liver involvement, that might be a key population to keep in mind for this treatment.
Yeah, I mean, if you'd asked me, I didn't know that, what you just said about giving Ipi-Nivo afterwards, but if you asked me to predict what the hepatic toxicity might be, I would have guessed that, because of the usual stuff about subclinical damage or inflammation in an organ system being a sort of, substrate, if you like, for increased risk of toxicity. So it feels it's a bit predictable, or potentially predictable. So is that everything that we needed to talk about? So, I mean, congrats, I think, to do the trial. This is complicated stuff.
Yeah.
And maybe good treatment for appropriately selected people, assuming availability.
Yeah, I think so. I think what's nice is, the duration so far that these patients are getting when it works for them. And then let's see about overall survival. We can fact check if they've reported anything on that, but it looks like a very reasonable option. And I agree. This is a massive congratulations. This company and the investigators really put their head down and kept going despite a really long, drawn out process and slow accrual and, et cetera. So.
Okay, thank you.
Thanks.
Okay, so this is a fact check for Melphalan HDS for uveal melanoma. There's a few things we talked about, right, Sapna? First of all, the most important one's the name, right?
Yeah. We weren't sure if it was Hepzato or Heptazo. It's Hepzato. Hepzato is the brand that it's marketed under. Yeah. We talked about, that was a study, the FOCUS trial that randomized to investigators' choice, but there was a high dropout rate because it was kind of uninteresting for those patients. And so that made us pop over to the Checkmate 037 study. You were reminding us that was Nivo versus chemo, and there was kind of a high dropout rate there. So maybe a few things on Checkmate 037. Can you remind us that citation?
Yeah, I think it's Larkin, JCO. Jeff Weber was the senior author, and then I'm quite hazy on the year. I don't know if you've got it in front of you, but maybe 2018, not sure. Does that sound right or not?
Pitiful fact check. We're having to fact check our fact check. Okay, fair enough. Maybe not a top 10 read for everybody, but that sounds about right. Yeah. And then importantly, though, you were telling us there was a pretty high discontinuation rate. And I think this rate surprised both of us when we saw it, right?
Yeah, no, I'd forgotten. I'm getting older on that anyway, but like 23%. for the people who are randomized to chemo. And so that was the whole thing. This wasn't a blinded study, so people could see what they were getting allocated. And I think at the time, pembrolizumab may have been becoming commercially available, certainly in the US. I'm not sure about other places when the trial was recruiting. And so I think what obviously would have happened, and we said this in the paper at the time, is that people were being allocated to cytotoxic chemotherapy instead of nivolumab. And understandably, to be fair, dropping out of the study at that point, potentially accessing anti-PD-1 via other routes. And actually, if you look at the overall survival in that study, it was really similar between both arms. And so we don't know, but we speculate that this is one of the reasons, or that was one of the reasons for that, which I think is plausible.
Well, the hazard ratio for that study for OS was basically 1. It was 0.95.
Yeah, 0.95.
Right.
Yeah.
So
which is really interesting, isn't it? Well, where you've got a treatment, nivolumab anti-PD-1, where it's very clear that there's durable benefit in some patients, versus a treatment cytotoxic chemo where we absolutely know that you don't really get durable benefit, but you can't see a survival benefit. So
that it's exactly what you say. It's what's not written in the paper, or what you have to almost read between the lines or know as an investigator. But what was happening at the time is they were dropping out. 1/5 of patients were dropping out, 1/4 almost, and then getting anti-PD-1. So then it ended up being this trial of anti-PD-1, on study versus anti-PD-1 off study almost.
Yeah.
Okay. We were also talking about where this was kind of done broadly. John Zager is the main guy doing it in the US. Southampton is a major center in the UK that was doing this Melphalan HDS, and I think still in clinical practice. And one of the guys that was doing it there is, we just wanted to make sure we acknowledged his name, Brian Steadman. So great option there if patients can access it. And then maybe I'll say that one first. We talked about ILP and PHP. And I reached out to Roger Olafsson-Bagge, our surgical friend from Gothenburg, and he gave us this really nice explanation. Do you feel nimble enough to describe it? The difference between IHP versus PHP?
So the difference is infusion versus perfusion. I think that's
right.
The first thing to say. So with infusion, some of the drug will then get filtered out, basically. So you need to keep infusing, and as a consequence, use more. Whereas with perfusion, and I think this would apply to an isolated limb as well, you have a closed circuit, basically, where you therefore need to use lower doses. So I think that's right, isn't it? That's the crux of this.
Yeah, and as I was editing our episode, I realized I think I said it wrong, because I actually described this Melphalan HDS as kind of a closed system. But as Roger really sort of advised, no, it's the drug goes in, it comes out, filters through a catheter, and then there's a fresh infusion of drug that goes in, comes out, filters through a catheter, a fresh infusion. So it's an infusion, whereas a perfusion would have been, like you said, a closed system, and the drug would just go round and round and round and round and round. In which case, in a perfusion, you can use a lower amount of drug than you use in an infusion, because the infusion is getting caught in the carbon filter each time it comes out. So what I said on the episode was just incorrect. It's not a closed system of catheters. You do still place catheters, but your part of this is that the circuit continues outside the body and goes through a filter. Now, I just said something wrong a second ago. It's not IHP versus PHP. All the I and the P stand for there is isolated and percutaneous. It's IHI IHI versus IHP. Isolated hepatic perfusion versus isolated hepatic infusion. So this system will often be called PHP, percutaneous hepatic perfusion, but as Roger has taught us, that's a misnomer. This is percutaneous hepatic infusion. So it's a non-minor point if you're the proceduralist, but it's just a semantics thing we should be careful. People will call it perfusion, but truly it's an infusion. So that's that. And then I think one of the last things we were talking about was the M category, the difference between M1A, M1B, M1C, either on this episode or another Uveal episode. It might have been this one, and how it's 3 centimeters, 3 to 8 centimeters and greater than 8 centimeters as tumor. And we were referencing the demographics table. And then we were just I was looking for a ruler to say how big is 8 centimeters. So I have a caliper here. You said 3 inches, which is right.
It's just over 3 inches, isn't it?
Just over 3 inches. You're absolutely right. So that's this. So it's the size of an apple, maybe, or an orange.
It's quite a large apple, isn't it? No? No?
No.
Average.
I mean, yeah, average. Average size for an apple. That's what we're saying. All right, good. Anything else we need to fact check for this one?
No, I mean, that was a fantastic use of props. And I'm glad we cleared that one up.
Well, let's try to have more props. Yeah. All right. Thanks, James.
Thanks.